I prepared this talk partly for them, and I learned some new stuff for myself, so I'm going to share it with you today. I'm excited to do that. So there are a number of reasons to have a talk about sleep and ADHD, partly because a sleep deficit can actually look like ADHD in full-blown form, especially in very young children. Children who are not getting enough sleep can get very inattentive and very hyperactive. But also sleep problems are often complications of ADHD, and sleep problems are more common in ADHD, and then parents of kids with ADHD need their rest. So when you put it all together, we should be thinking about sleep and ADHD all the time, and actually the American Academy of Pediatrics guidelines, they only get like a few phrases for each thing that they want you to do, but addressing sleep at every single ADHD visit, I think is totally critical to the management of kids with ADHD. And occasionally you'll actually cure somebody of their ADHD, but we'll talk about that a little bit later, by improving their sleep. So sleep problems in general are actually very common. Young children especially, up to 30% of them will have significant sleep disruptions for at least a week at a time. And the kids get sleepy and irritable, and the parents get exhausted and irritable. But I think part of what we want to talk about today is the fact that inadequate sleep also interferes with optimal attention. Uh-oh, somebody has to leave the building. Yep, sorry. See if you can mute your phone if you're the ones having the fire drill, please. Thank you. So it can interfere with attention. It can certainly interfere with mood and make mood disorders worse. It can make hyperactivity worse, and it actually interferes with learning as well, which is part of what we're going to talk about today. But it's an interesting fact for your teenage patients is that sleep debt is about the same risk for dangerous driving and accidents as being intoxicated with alcohol. By the way, so is ADHD that's unmedicated is about the same as driving intoxicated. So these can be additive effects, and it's really a big problem for your teenagers. Lack of sleep is actually destabilizing for mental disorders, for example, bipolar disorder. And one of the sort of major pillars of management of bipolar disorder is to make sure the person's getting enough sleep, which isn't always easy to do because it can make things much worse. And sleep problems don't just go away on their own. The reason I've got down here last 3 years of untreated is because that's when the grant fund ran out for Dr. Lozoff, who was studying this. And so things were still not better at 3 years if you didn't do anything about it. But they're often resolved pretty easily, and often at least the parents are motivated. Sometimes the kids are not so motivated, and that makes it harder to do. So what does sleep do to learning? Well, a quarter of high school students are asleep in school at least once a week. Well, if you're asleep, you're not getting anything out of it. So that's certainly a way of interfering with learning, isn't it? But in addition to that, there's some pretty clear data that memory and attention are both worse if the person does not have an adequate amount of sleep. And children become more irritable and impatient, which doesn't help them with learning, which is, tedious. It's frankly a lot of things that kids have to learn and that we have to learn are tedious. And so if you're in sleep debt, you're not as patient with going through all of that. So just to remind you about sleep architecture, because it's relevant here for a minute, what you see over here is at the top is when people are awake, and then the stages go down to stage 4, and you'll see that the deepest stages of sleep are in the earliest part of the night, and that most of the REM sleep is at the end of the night. That's over here. And then stage 2 is this stage right here, and I'm going to refer to stage 2 and to slow wave sleep, which is mostly here. So I'm going to refer to those things in a minute when I talk about the effects on sleep and learning. So it turns out that not having enough sleep gets in the way of physical reflexes, fine motor skills, judgment, and insight. And those are pretty broad terms. So what do we know a little bit more specifically? Well, the less non-REM sleep, that stage 2 sleep that you get, the worse is your non-declarative learning. And non-declarative learning is like skills learning. So when you don't have that stage 2 sleep, you're having trouble remembering what you've learned of motor skills. The less REM sleep you get, and you notice that that was later on in the night, the poorer your declarative learning, and that is learning of things like facts and things that are sort of, I think of declarative as sort of being verbal. So things that you need to remember that are not motor skills but are more cognitive concepts and facts. So sleep itself has been a mystery for forever, basically, and more of it is getting known, but it's still kind of mysterious. But sleep not only prevents the decay of memories, but also helps with actively fixating declarative memories into your short-term, and then, as you know, it goes from short-term into long-term memory. And that the process of sleep helps clean out the weak connections, allowing the stronger ones to persist. So you get rid of the junk that you don't need. And actually, you probably were interested in some of the data that came out recently about the fact that there's a specific kind of opening up of the flow of cerebral vascular fluid during the night when you're sleeping. The channels actually increase in size and flow, and protein trash is basically helped to be washed out. Now, what is that protein trash? Well, there's less activity in the central parts of the brain during sleep, and this corresponds to less anxiety in people who have a tendency to anxiety after they've had adequate sleep. All of these effects that I just talked about in terms of fixing in memories, getting out unneeded information, and producing less anxiety, all of those effects are larger in children. They have a larger sleep need, but they also have a larger effect in terms of having deficits when they don't get enough sleep. What do we know specifically about sleep and ADHD? Well, one of the things we know is that consolidation of declarative memory that I was talking about, so facts and concepts, is supported by that slow wave sleep that I showed you, especially in the beginning of the night. And that slow wave sleep is generated by the prefrontal cortex. Well, as you know, ADHD patients have relatively low prefrontal brain activity compared to people without ADHD, and therefore children with ADHD actually have less memory consolidation during sleep than people who don't have ADHD. So that's pretty scary, but it may help explain some of what we see about poor memory in kids with ADHD. It's not universal that kids with ADHD have poor memory, but a lot of them do, and it's a big problem because it's hard to know exactly what to say to them to improve that situation. Well, here's at least one thing you can say, and that is get enough sleep. So this is another study about ADHD and sleep problems. They found that about 41% of kids with ADHD had no problems with sleep, 49% had transient sleep problems, and 10% had persisting sleep problems over a period of about 22 months. Now, I personally think that these numbers are probably too low, but if you add together the 49 and the 10, well, that's pretty close. So that's about 60% of kids with significant sleep problems. And what they found was that kids with internalizing and externalizing comorbidities, as well as more severe ADHD symptoms, were more likely to have both the transient sleep problems and the persistent sleep problems. And we are probably seeing that, whether we think that it's due to the anxiety that's keeping them awake or due to the disruptive behavior that keeps them from complying with going to bed. In the end, they ended up having worse sleep problems. And in fact, externalizing disorders and the use of ADHD medication was related to a higher odds ratio for persistent sleep problems. Now, another study, it's a different study by different authors, found that sleep problems were significantly predicted to have greater oppositional defiant disorder symptoms, general externalizing behavior problems, and depressive symptoms a year later, controlling for the initial level of these symptoms, so controlling for initial levels of comorbidity, ADHD severity, and even for socioeconomic class.
Barbara, can I ask a question just to clarify? When you have on the slide sleep problems, what do you include in what counts as a sleep problem for these studies?
Good. So they were using parent rating scales. So they were not using sleep studies of physiological changes in sleep. They were getting a parent report of sleep problems.
And is that difficulty falling asleep, staying asleep, getting enough sleep, power struggles at bedtime? Is it the actual amount of sleep, or how hard it is for the parents to get the kid to go to sleep?
That was a very good question. It was all clumped together in this particular study. And, of course, that's sort of what you just described was there are all kinds of different sleep problems that occur in ADHD, including getting into bed problems, falling asleep problems, getting up in the middle of the night problems, not obeying and turning off your electronics. So there's all kinds of things that could happen. They included them together. So I'm not sure how useful this is clinically to see this. It may be that the kids, but it does say that they were controlling for comorbidity, so they weren't the most oppositional kids necessarily, then becoming more oppositional later. So it's an interesting fact. So that's really the science I'm going to give you, and then the next thing I want to talk about is, there's a little more science, but like, what can you do about this stuff? So let's just start with what we know about sleep hygiene. So some of the things that are well recognized as improving the quality of sleep include sleeping in a cool, dark room. That's real easy because it's freezing here right now, but in general, keeping the room cooler and keeping the same schedule 7 days a week. That one, to me, clinically is one of the biggest problems, is convincing people that it's not a favor to anybody to let the kids stay up and watch movies till 2 a.m. on Friday night because it messes up the rest of their sleep schedule for the rest of the week. Avoiding exercise within 2 hours of bedtime. I have to say that basketball practice at 9 p.m. doesn't help this. Avoiding stimulants like caffeine, tea, nicotine. Don't forget some of your patients actually are smoking, as well as certain medicines, which I'll mention in a minute. And avoiding electronics for at least 1 hour before going to bed. Again, easier said than done, right? So keep in mind that bedtime is kind of a scary time for people. That's kind of the basis of sundowning in old people, for example. It gets to be dark, everybody wants to feel safe, and in fact in animals, they clump together at night to feel safe because that's when the predators are out. So thinking about it from a biological point of view, it's important to feel safe in order to let go of your consciousness, which also means that it's not a good time for having arguing or watching violent or exciting media. Instead, it's much better to have a story and positive talk before going to bed. The other fact is to avoid sleep associations that can't be reproduced. So we all know about pacifiers in babies, and falling asleep with a bottle in your mouth can make the baby wake up later in the night, as we all do, but not be able to go back to sleep on their own. Well, the same thing can happen with school-age kids with ADHD who are falling asleep with their electronics. That can become the sleep association, so when they wake up in the night, they look around for their electronics or their TV to go back to sleep. And all of that requires that they wake up more in order to sort of get the device turned back on and everything, so that they are less able to just easily fall back into sleep. So let's just talk about dysomnias for a minute, keeping in mind that dysomnias can be caused by lots of things, including a noxious environment, a chaotic or noisy household, living next to the fire station, being frightened about whether there might be intruders. All of those things can interfere with sleep. You can also interfere with sleep because you're too tired. Sometimes if you're too tired, you get too wound up, it's harder to fall asleep. And dysomnia, NOS, is used to describe other kinds of insomnia that don't meet disorder criteria. Now, one of the things that I think is interesting and that I'm starting to ask about and haven't particularly before is that some kids have trouble falling asleep because of restless leg syndrome, which is actually more common in kids with ADHD than it is in the general public. And it's uncomfortable for them, so they're kind of not wanting to go to sleep because they don't want to have that very uncomfortable situation. And if you have any adult friends who have this, or if you have it yourself, you'll know that it doesn't make going to bed very pleasant. So I already mentioned sleep association, so I'll skip that one over. But let's talk about the problem of falling asleep. So usually this is a phase shift problem. In other words, people are in a habit so that they've shifted their time for falling asleep and getting up outside of the range when they actually need to do it. And often just keeping a sleep chart can help you figure this out. Some other things that can help with people who have trouble falling asleep include having more exercise during the day, making sure that you have a routine. Again, 7 days a week is the best. But if you have a person who's been staying up really late at night, there's a very useful technique that I don't think is talked about quite enough, and that is to have the child start their bedtime at the time they're naturally falling asleep. So if they're naturally falling asleep at midnight, start bedtime at midnight, and then work backwards by 10 or 15 minutes a day, keeping the morning wake-up at the new recommended desired amount of time for being asleep. That way there's not a big struggle because the child is actually tired when they're going to bed. The other thing to keep in mind is that some people are taking naps. Some kids with ADHD are coming home from school, taking a nap. They may be there by themselves, but once they've had a nap, that first deep sleep cycle, which is what allows you to go into sleep, is that drive to go down, down, down to level 4. That one goes away when you take a nap. That's why naps can help with night terrors, because the night terrors tend to occur after the first deep sleep cycle. But the problem with naps is that they make it hard to fall asleep. So getting the circadian rhythm lined up and keeping it preferably exactly the same, meals and sleep time every day, but if not exactly the same, no more different than about 1 hour from the usual desired amount of sleep. And that's what sleep centers recommend. Some children are so sensitive they can have no play in the system at all, and they can't even have 1 hour difference on weekends. And other children can manage with 1 hour difference on weekends. So how about this insomnia? Well, here's a classification system in insomnia, which I think you're going to get a good chuckle out of it if you haven't seen it before. And that is, first, the child's symptoms have to meet criteria based on parent report or adult report, and that there are two kinds of insomnia. One is called sleep onset association type, and that is what I mentioned. Falling asleep is an extended process that requires associations that actually get in the way, and that it therefore either delays onset of sleep or disrupts sleep later and requires adult intervention in the middle of the night. The second kind is the limit-setting type, which is you can't get the kid to go to bed, and that's a limit-setting problem with the adult. And then part C is the usual reprisal, which is sleep disturbance not better explained by another sleep disorder, medical and neurological disorder, mental disorder, medication use. So these are actually criteria from the International Classification of Sleep Disorders. At least now you have a name for it, right? But I think that you probably already knew those things. Now, this next slide I want to show you came out like 2 weeks ago, and that is a very large consensus of sleep experts were convened to say, well, what are the sleep requirements at different ages? And these are somewhat different than what you've been hearing before. So let's just look at the school-age kid down here, 6 to 13-year-old. The dark blue band in the middle is the recommended amount of sleep, 9 to 11 hours. And then the turquoise bands are the range of what might be okay, depending on the kid. So 7 to 12 hours for school-age kids. Now notice there's actually an upper limit too. In other words, if you're sleeping too much, there may be something else wrong with you. That's not normal either. And then for teenagers, who are often the ones we're dealing with, the range is 8 to 10 hours, with the broader range being 7 to 11 hours. Now, how is that different from what the previous sleep recommendations were? So you can see that here that for school-age kids, the sleep range was widened by 1 hour. It was previously 10 to 11 hours. Now it's 9 to 11 hours. And for teenagers, it was widened again by 1 hour. It was previously 8.5 to 9.5, and now it's felt to be 8 to 10 hours. And by the way, if you're checking out for yourself, I'm sure that you're in this category right here, which is it's still 7 to 9 hours of sleep. If you're getting less than that, you're not getting this recommended amount of sleep. So how are our teenagers doing? Well, a recent study of 270,000 teenagers found that 63% of the 15-year-olds were getting 7 hours or more. At 13, about two-thirds get at least 7 hours. That's pretty similar to this. But at 18, only a third of kids are getting the recommended 7 hours of sleep. And I thought it was interesting that girls actually get less sleep than boys. I would have thought it was the other way around, but maybe the boys are wearing themselves out or the girls are still chatting. I don't know what it is. This report pointed out that lack of sleep is also associated with obesity, depression, and poor school performance. It didn't mention anything about learning and memory, but maybe the school performance is sort of the proxy for that. This is the kind of diary you can get from the National Sleep Foundation, which gives a family a chance to sort of go through the factors that they might need to figure out where they're getting stuck with sleep. But I would say the majority of the sleep problems we're seeing in kids with ADHD are a circadian rhythm disorder, meaning difficulty getting in bed at the right time and then difficulty waking them up in the morning. So what is the problem when people are just having trouble going to sleep? Well, first of all, primary insomnia that we associate with adults should be a rare diagnosis in kids. It's really a diagnosis of exclusion. Mostly that primary insomnia doesn't occur until adolescents or older. So what is the insomnia that we're seeing in kids with ADHD? Well, mostly it's a phase shift problem. They're going to bed at the wrong time and they're not getting adequate amount of sleep. Sometimes it's an anxiety problem. Anxiety is frequently comorbid with ADHD, and they're lying in bed worrying about stuff, like what's going to happen the next day, how they did on their test, whether that girl's going to talk to them or not, whatever their anxiety might be about. And sometimes much more serious things, of course, like sexual abuse or PTSD symptoms. I don't want to forget that. So in order to have primary insomnia, you have to have at least a month of significant trouble falling asleep that interferes significantly with functioning or causes distress, and that's not part of another one of these sleep or mental disorders. So some of the things that can be a cause are here. So excess exercise too close to bedtime, smoking, caffeine, naps, sleep association, sexual abuse. Those are all things to think about. But don't forget to think about the negative association of breathing-related sleep disorders, otherwise known as obstructive sleep apnea, which I'm going to get to in a minute, as well as restless leg syndrome. So what do you do if you have somebody who does seem to have a problem with falling asleep? Well, take care of the stresses in their life, easier said than done, of course. Often desensitizing them to their bedroom. So if they have a negative association with being in their bedroom, sometimes move the bed over to the other side of the room, or remove the alarm clock or turn it around so they can't see it. Include a comforting routine with the adult. That's often missing in school-age kids, but can be very helpful to talk in a positive way, not just watch a movie and then go to bed. And then the same principles that work for adults with insomnia can work for kids, which is if it takes more than 10 minutes to fall asleep, get them up, keep them up for an hour, and then let them try again. This results in a sleep debt, which makes it possible to then get into sleep more easily and stop resisting. And, of course, no naps, really important, no naps. Medication is really a secondary treatment. So you should be always thinking about sleep hygiene first and only thinking about medicine later. And I'll say some more about medicine in just a minute. So what is it about teenagers? Well, they don't go to sleep because they don't want to, mostly, right? They have the worst possible school schedule because when you're in puberty, you actually have a tendency to have your melatonin, your natural melatonin surge occur later in the evening, so that they would naturally fall asleep later. But now they have to get up earlier because the stupid school bus comes for them at 6:30 in the morning. And often they're awake with electronics or with their cell phones going off. Even if they're not initiating it, they haven't turned it off completely. And people very frequently have people texting them in the middle of the night, even if they weren't starting it. Sometimes kids like to stay up late at night and sleep in during the day because they don't like to talk to their parents or they don't like to go to school. And this is sort of their way of avoiding all of that. So if you have a teenager who's willing to change their sleep schedule and they're way off, like they're going to bed at 2, sleeping in until 10, or worse than that, maybe going to bed at 2, getting up at 5, and they're in bad shape, you can either work their schedule backwards or forwards by 1 hour per day. So if they're at 2 already, it might be good to stay up till 3, and then stay up till 4, and then stay up till 5, and then stay up till 6, and work your way all around the clock. A good time to do that, of course, is usually a vacation time, or you can sometimes move them backwards, 2, then 1, then 12, but they have to get up at the same time every morning. So that does require a lot of cooperation. There are people who think that you may be able to reset the clock by simply having them stay up all night one night and then start going to bed at the right time the next night. It's worth a try because it's not quite as hard. But the hardest part then, once you've got them on a reasonable schedule, is this one, which is to keep the schedule within 1 hour, 7 days a week. Okay, so let's just say something about anxiety and sleep. So sleep onset and sometimes waking in the night can be due to anxiety disorders as well as anxiety problems. And sometimes kids obsess over how long it's taking them to fall asleep or things that they're worried about. This can also be part of separation anxiety disorder, particularly in younger kids. So what can you do about that? Well, when there's externalizing disorders, often they've been sort of in a battle with their parents all day, so they aren't feeling good about their relationship. So that doesn't help with that need to feel safe at bedtime. So helping parents and children come together with better, calmer limits and having some positive time with the parent is really important. And, of course, managing their ADHD symptoms so they aren't such a pain in the neck. That helps, too, and that they're more cooperative with their parents. For the internalizing disorders, things like separation issues can sometimes be fixed by letting them sleep in the same room or even in the same bed with their siblings, if the sibling's willing to put up with it, or sometimes the dog, if the dog's willing to put up with it. And certainly putting on a nightlight can help. These are sort of practical strategies. I mentioned for those kids who obsess about how long it's taking them to fall asleep that either take the clock out of the room or turn it around, and to be sure to help them with calming books. There are younger kids who are nervous about wetting the bed, and that's the reason. And if you don't ask them about that, they won't report that to you. But sometimes putting them back in pull-ups if they're really not ready to be dry yet, or giving them training for their enuresis can be helpful as well. And then there's also the kids who are lying in bed a long time, and they don't really have a specific thing they can report. They just don't like lying in bed all that time. Sometimes those kids actually need a later bedtime, but again, wakening them on time. For kids who have a real bad thing going on in their life, of course, like bullies or PTSD or learning disability, you would want to be addressing those things. So more literature points to between 50 and 85% of kids with ADHD having disturbed sleep. And interestingly enough, this generally precedes any use of medicine. So you really don't want to blame sleep problems in ADHD on the medicine itself, even though it can do something bad to your sleep. And if the history is that they were sleeping fine until they took the medicine, that can make a difference. So what do you do about that? Well, improving their sleep hygiene. Make sure they're allowed to get enough food before they go to bed. Remembering that kids who are on stimulant medication probably didn't eat enough lunch, or maybe none at all, maybe not have even had enough dinner, and they need to eat before they go to bed. And if the parents don't let them and get dogmatic about that, they can be hungry, and that doesn't help. And sometimes giving medication for ADHD in the evening can help. So let's just talk about medication a little bit here as we close out this part of what we're talking about. So some of the things we know that make sleep worse include caffeine, nicotine, theophylline, if anybody's still using that. Stimulants have that as listed on their list, and it can certainly do that. Antihistamines, including Benadryl, can make things worse as well. You can have sleep that looks okay, but it's actually not fulfilling your sleep needs if you're on valproate or diazepam, because it changes the normal architecture of sleep. So that can be an issue, too, if the child seems tired, even though they were in bed long enough. So it's really important to remember that medications rarely solve a sleep problem alone, even in ADHD. But sometimes they can be helpful, and probably the one that people appreciate the most because it's non-prescription is melatonin. 3 to 10 milligrams can be given an hour before sleep, maybe even having the child wear blue sunglasses to reduce the stimulation that they're getting from either ambient light or computer light. I just learned about an app that allows your cell phone to reduce the amount of blue light it emits over the course of the day. I have no idea if there's any evidence of that. But I recently learned and have been doing something a little bit different, and that is providing sublingual melatonin, because you don't have to remember to take it in advance. And you can take 1 to 5 milligrams before you go to bed, and then have another one right by the bed because it works so fast that if the child wakes up in the night, they can stick it under their tongue, and they will be able to go back to sleep. So that can be a really helpful adjunct to the over-the-counter melatonin that you might know that people are getting. Clonidine has been cleared as being okay, even when you're using stimulant medications, as long as the child's heart is normal, of course. And the dosing is between 0.1 and 0.3 milligrams, again, an hour before bed. But sometimes the reason kids can't fall asleep is their ADHD, its medicine for the day is worn off, and they actually fall asleep better if they still have some on board. So some of the good ones for that are the long-acting meds like Concerta or Daytrana or even Quillavant can help them ease into sleep. Guanfacine and Intuniv, which are both alpha agonists, can also be helpful in falling asleep and sometimes are indicated for other reasons as an adjunctive medicine or even as a monotherapy for the ADHD. But notice when you're giving it. So Intuniv lasts pretty long, and how long it lasts depends on the kid to some extent. So sometimes if the kid is taking the Intuniv in the morning, it helps with their ADHD, but they're having trouble going to sleep, and they might do better taking the Intuniv in the evening. So just something to think about. Now, should we ever be prescribing Ambien? I personally don't prescribe Ambien. It's addicting. It has carryover sedation, and it gradually loses its effectiveness if it's used chronically. So it's not one. I try to work on everything else rather than that. And these medications, now diphenhydramine I just mentioned is probably not recommended because of daytime sedation and sometimes even makes sleep worse. Trazodone and cyproheptadine, they do work, but they are big guns, and if a kid is having such a severe sleep problem that they need that, probably they need a consultation anyway. So I just want to finish by telling you about breathing-related sleep disorder and then showing you some questionnaires, or at least one questionnaire that can be really helpful to you. So, central apnea and obstructive sleep apnea are both the two kinds of breathing-related sleep disorders, central apnea being primarily one in either preemies or kids with neurological deficits. And obstructive sleep apnea is defined as at least 5 10-second apneas or DSATs down to less than 50% of normal per hour. But the part that's really incredible is that some people with sleep apnea have 300 apneic episodes a night. This could be so bad that they actually develop failure to thrive. But in any case, they certainly aren't rested when they wake up in the morning. About 1% of kids have obstructive sleep apnea. Only 75% of them are snoring. So that means that snoring itself is not an adequate way to determine. So if you suspect that the child is not getting good quality sleep, a sleep study is indicated even if there's no snoring. So some of the other things they might show are paradoxical breathing, grunting, choking, gasping, sweating, which I think is really interesting. Heavy sweaters may have sleep apnea, posturing in the bed, being restless or distressed on awakening, and of course the effects of sleep apnea are not just on your mood, hyperactivity, attention, and memory, but also can produce heart problems, hypertension, core pulmonale, cardiovascular accidents, and death. Those are basically in adults, but the seeds are being sown in kids. Some of the things that predispose are large tonsils and adenoids, obesity, hypotonia, drinking, alcohol, or syndromes such as Down syndrome, which is associated with sleep apnea. Now, most of them are fixed by tonsillectomy and adenoidectomy, but not all of them. So I mentioned the restless leg syndrome. Just be a little bit more aware of that. It's a familial problem, pretty common, 2 to 5%. And as I mentioned, kids with ADHD are more likely to have this, especially those who have worse ADHD symptoms. The treatment is not perfect. There are some medicines that help. You can see all kinds of medicines here, ones that I've never actually recommended, and certainly I'm not about to give oxycodone to somebody these days. And so these are probably things that should be used by sleep specialists. But there is data that iron supplements may help the restless leg syndrome, and is that certainly a safe treatment. Massage and cold compresses can help with. So we want to remember that sleep can be a part of any mental disorder, and being up in the middle of the night for several hours, running around doing different things, may be a sign of bipolar disorder as well. So we want to keep that in mind. Kids don't usually have the same sleep effects from depression as adults do. So what can we do to diagnose this? So why don't we take some questions while I pull up the other screen, where I'm going to show you this questionnaire that we've created along with Judith Owens. Now, Judith Owens, you may have heard of. She's the author of the Children's Sleep Habit Questionnaire and the Bears, and we combine these into one questionnaire that's available on Chattis. Basically, we want to collect information on how much sleep is the child getting, and I'm going to give this kid, time on weekdays. So let's say they're doing a good job going to bed at 8, they're waking up at 5:30 for school. Bedtime on weekends, though, 2 a.m. and sleeping in until 10:30. So that would be a bad circadian rhythm setter. Are they taking naps? If you say yes to this, you will be asked how long it is and how late it goes. So what's the latest wake-up time? Remember, 4 is really kind of the cut line on that. And then these are the sleep apnea questions that are being used in the new PCORI sleep nationwide survey. So asking about snore a lot or difficulty breathing at night. And then from there, it could be loud snoring, stopping breathing, snorting and gasping, and then asking if they've been diagnosed or treated for sleep apnea. And then these are the risk factors that they are asking about. So tonsils, allergies, or asthma. Asthma, by the way, can cause you to avoid sleep as well because children do more wheezing in the night and it makes them scared and uncomfortable. So being overweight, Down syndrome, family history of sleep apnea, family history of gastroesophageal reflux, and then problems going to bed could be a variety of sleep association. I'm checking off everything here. Sleep association or struggle at bedtime. And sleeping during the day can also be a clue, any of these things, including falling asleep suddenly even while awake can be a sign of narcolepsy. So, and then things that happen during the night called parasomnias can include night waking. It can include bedwetting. It can include sleepwalking. It can include night terrors, which are waking screaming, and, of course, nightmares. So these are all some of the bad things that happen. And then the parent's opinion. Oh, well, I guess that kid should have a yes here. And when you submit it, what you can then see is a report of which provisional sleep diagnoses may be present, and I don't want to include all that stuff in this report, so I'll just make that one thing. And what you can see here is I basically gave this kid everything, right? Possible sleep-related, breathing-related sleep disorder, sleepwalking, sleep terrors, nighttime nightmare disorders, inadequate sleep, sleep rhythm problems, and then these risk factors for breathing-related sleep disorder. And rule out narcolepsy came from the falling asleep even when active. So all of that is available to you in Chattis if you're interested, as well as further decision support and things like that. So that's what I wanted to talk about, and now I want to hear some of your ideas about sleep problems. We've got a number of behavioral developmental experts on the line, including Emily. Your suggestions or your cases where you're getting stuck dealing with sleep problems.
This is Emily. Barbara, thanks. That was a really wonderful review of all the various permutations that are connected to sleep. I think the only thing that I might add is that before thinking of sleep as an isolated symptom that requires a targeted intervention, I think it is really, really critical that we question whether it is a symptom as part of a clinical syndrome, and we should be treating the underlying syndrome, of which sleep is one of many symptoms. And I can't underemphasize the importance of looking for depression, because I see this over and over again, the youngster who's on ADHD and is on a sleeper medicine because they're having trouble sleeping, but really the sleep is one of many symptoms of depression, and the depression has gone untreated. And the families are very baffled as to why things aren't getting better, and it's because there's depression that the sleep was the ticket to, but it didn't get recognized. And so I can't overemphasize how important it is to when thinking about if there's a sleep problem, could this be one symptom of the syndrome of depression that requires targeted intervention rather than chasing the single symptom?
That's an excellent comment. And would you comment on people with ADHD, of course, have higher rates of both depression and anxiety even at the disorder level, but it's not always evident when they're young and the diagnosis is first made of ADHD. Can you comment on at what age you tend to see this happening, that they are depressed, specifically in ADHD? I realize that's not what you were talking about exactly because
sure.
you're saying
I mean,
and food.
I think there are a couple of things that I always try to look for. One is whether there's a family history of any affective illness, because that's going to increase the risk for that youngster right then and there. The second is whether there's active illness in anybody else in the family, because that's going to make the parenting less successful, and so the youngster may have more difficulty as a result of that.
So how about the age of onset? Can you comment on that? Like when the
and we see depression in preschoolers and in elementary school age kids and things like that. And so I think sometimes when kids are off task and inattentive, the reality is it's relatively easy to treat ADHD, and so many of us will reach for ADHD interventions in the younger kids because they look off task and inattentive and they're not being successful in school or with friends. A portion of those kids probably don't have ADHD. They may get some response to a stimulant, but some of them are actually having some affective illness or an anxious presentation. Many of those youngsters may have more trouble tolerating stimulants. So we see kids that struggle with this at all ages, Barbara, I would say. I don't know that there's necessarily an age after which you always think about it. I think we need to be open. People tend to think about it more in the teenage years, but I don't want to say that people shouldn't think about it in the school-age kids, because I think it often goes unnoticed and can contribute to why kids are not getting better or being more successful with their ADHD treatment. So one key would be, if you are managing a youngster with ADHD, and the reality is if they really have ADHD, you should be able to get a good response to one or the other classes of stimulants in almost 90% of those youngsters. Anytime you don't get that, and sometimes you have to play around with which class of stimulants you're using, anytime you don't get that, though, I think it's important to just step back and say, could this be something else, and could it be depression or anxiety that may be making them look off task and inattentive and even explosive and aggressive? And so I think it can be at any age, really, and that's where the family history can be informative.
Mm-hmm. Very good. With what Emily said earlier about sleep being a symptom and look for the syndrome, but I also think, we used to hear that syphilis was the great imitator. Well, sleep itself, I think of as like a syphilis. It imitates these other things, and sometimes addressing sleep first, especially in younger kids. And with this particular kid, what you see is it's the issue of parents' inability to set limits and structure. That is a thing that you discover by trying to address the sleep. And so I usually try to, let's fix the sleep problem and see what's left over. Then you can look at ADHD and some of these other things, and then you might discover that, it is some other syndrome. But once you've addressed it, it doesn't hurt to try to address the sleep problem. It's not like giving them a medication. We're having to deal with some of these behavioral issues also.
One thing that I've always felt very helpful, especially for parents who have trouble with limit setting at bedtime, is the bedtime pass. And that's
good. Tell some more about how you use it.
Well, I just talk to parents about getting an index card and involving the child and make a bedtime pass, and then set the rules that at bedtime I give you the bedtime pass, and that if you have to get up for any reason, you have to surrender the pass, or you can choose to keep it, and tomorrow you can exchange it for a reward or treat.
Nice.
And
nice.
I think that has at least given the structure that some parents need to really kind of work on the, limit setting at bedtime.
One of the nice things about that, Dawn, is that it makes the parent feel less mean.
Mm-hmm.
And so they're more likely to do it because they feel less mean. So I think that is a good strategy. Thank you for sharing that.
There's also a nice article about it in Pediatrics showing the evidence that it works. Very nice.
Barbara, I've utilized on the other end of the time scale is, before they go to bed, I ask my patients to journal, and for the younger kids who are too young to really write out or don't feel like writing out, I have them draw pictures, and I have them either write or journal or picture about something that was good that day, something that was bad or made them angry that day, and something they want to remember from that day. I tell them it's private, it's for them, but if they, over time see that they're writing about the same bad thing, that they should probably show it to somebody at that point so they can start learning different ways to approach that issue so it won't make them feel so bad. I explain to them that getting the thoughts out of their head sometimes, helps them to be able to keep a clear mind so they can go to sleep a lot more easily. And the people who have committed to that have had pretty decent success with having that help take away some of the bedtime thoughts that swirl through their head that keep them from sleeping.
Well, that is lovely, Wendell. And, of course, there are a couple side benefits, and that is if they're journaling, as long as they're not journaling on their computer, that means they're away from electronics, which is good.
Right.
And it's interesting because adult insomnia, one of the recommendations for adult insomnia is to write down any of those things that you might be staying awake, trying to remember for the next day, that it actually, as you said, helps you clear your brain to be able to relax and sleep.
Tell parents to read bedtime stories to kids when they're young. And I think once they get to be able to read and they say, oh, you read to me, and they make it into a kind of homework thing at night, and that sort of dissolves. I've been inclined to try to encourage parents to read even as long as the kids will allow them, even as they're teenagers, when they read about something of common interest. It gives a routine that is makes this kind of safe environment that Barbara talked about and helps with parent-child relationships.